Hello and welcome to EHJ Today. My name is Gerhard Hindricks and we are here in Barcelona for the annual scientific sessions of the European Society of Cardiology. It's my privilege and pleasure to introduce Professor Jean-Jacques Blanc from France and Professor Cecilia Linde from Sweden to you, and we're going to talk about BIOPACE, one of the most important studies in cardiac resynchronization in pacing that has been conducted over the last couple of years. Jean-Jacques, welcome. Cecilia, welcome.
Thank you.
Jean-Jacques, can you give us the background for the BIOPACE study, please?
Of course, it's the BIOPACE was a program, I would say, about more than 10 years ago, and at that time, the treatment for chronic persistent AV block was right ventricular pacing. But we started to know that in some cases and in some studies, this right ventricular pacing had some deleterious effects due to the desynchronization of the left ventricle, because of course when you pace the right ventricle you have a left bundle branch lock pattern. So there was desynchrony of the left ventricle, and this induces some clinical heart failure in some patients. That was very well demonstrated. So our rationale was to think that perhaps if we pace both ventricles, or at least the left ventricle predominantly, we would avoid this desynchrony and then improve the patient outcomes.
How many patients did you include in the BIOPACE study, and what was the primary outcome parameter?
Yes, we have included, and after a full calculation by the statistician, we needed to include more than 1,800 patients. So finally, we have recruited 1,810 patients, and these patients were randomly assigned in both groups: RV pacing, right ventricular pacing, and BIV pacing. And the first, the primary endpoint is a hard endpoint because it's death, time to death, or time to first hospitalization for heart failure. That's a combined endpoint.
What was the follow-up of the study, and what are the key results? I mean, this is the first time that the results will be presented to the scientific community, I think tomorrow morning or Monday.
Monday. The main result, I would say, is that we have a tendency that BIV is better than RV, but this difference does not reach the statistical significant 0.08. That is close, but not. Just to go a bit further, the hazard ratio is 0.87, between 0.75 and 101. So very close to be statistically significant, but not yet.
So there was a trend towards a better outcome with cardiac resynchronization in the patients treated, but it did not reach statistical significance. The follow-up was how long?
The follow-up, sorry, I haven't answered to this question. The follow-up is very long. It's very long for such a study because it's 5.6 years. So the mean follow-up is more than 5 years.
Cecilia, is that surprising to you?
Well, I mean, there's a big difference between this BIOPACE trial and BLOCK HF, which is the other trial that focused on bradycardia. And that is that in the BLOCK HF, people were included for left ventricular dysfunction. In BIOPACE, they were included irrespective of left ventricular ejection fraction. So you have patients who have a much better cardiac function in your trial than in the previous trials. Also, the patients here are probably in their 75s or so on the average. And the question is really, is it worthwhile to give an elderly patient with high degree AV block a CRT device for marginal benefits, or is it the risks greater by introducing a cardiac desynchronization therapy device that has more complications, etc.? So that is what will have to be analyzed, I believe, following your presentation and then subsequently the publication.
Yeah, you took a very good point. First, as you mentioned, the mean ejection fraction for the group, for the cohort included in BIOPACE, is 55%, which is almost normal. And the second point is that, and that is identical to BlockHF, the mean age is 74 years old patients. And so we are in trouble, I would say, because if you are just a scientist, you will say 0.08 is not statistically significant, so keep as we are. RV pacing, which is more easy and cheaper than BIV pacing. But if you are as a physician, you have to take in, you cannot ignore that we are close to, there is a clear trend in favor of BIV. And don't forget that in other studies there is also a trend, or sometimes significance, in favor of BIV. So we are really in trouble, and I think that subsequent analysis will perhaps help us to choose the patient that will really benefit from BIV pacing, and those that will have to be kept to RV.
Well, I suppose it's early days now, but there will be subgroup analysis, no doubt, looking at the impact of ejection fraction in this trial. I'm sure there are a small subset who have low ejection fraction.
We have this result, and I will present this result. And we divided the patient, and that's pre-specified. It's not a secondary analysis, it's pre-specified. We divided the patient into different subgroups, and to make the thing simple, I would say, we have chosen patient below 50% with a mean ejection fraction identical to that of BlockHF, 40%, 41% ejection fraction, and those above 50%. And the results are clearly identical. No significant. The significance is closer in patient above 50%.
That's interesting.
Above 50%.
Jean-Jacques, do you have any data at this point in time whether the percentage or intensity of right ventricular stimulation versus biventricular stimulation plays a key role? You did.
Yes, we did that. That's also a different point from BlockHF. We measured the percentage of pacing at 1 month, and it's around 90%. 90% of the time the patient are paced at 1 month.
So I just would like to make one more point. I mean, the BlockHF trial, there are patients there with clearly low ejection fraction, and the results show that there is a reduction in death and hospitalizations for heart failure, as well as a postponement or deterioration of left ventricular function. But these patients most often have low ejection fraction. And whereas your patients start out being predominantly sane patients, the ones that we encounter in our daily practice. And I think it's a good balance and a good challenge for the guidelines committee to come to grasp these two trial results, because there won't be any more studies, and try to make something of it. But if I could sort of guess, I would guess that there will be an element of left ventricular dysfunction in any recommendation for CRT in bradypace patients.
Yeah, that's what I would also foresee. If I look to the different pieces of scientific data we have, and the study that Jean-Jacques was the primary investigator in significantly adds to that, although the results may, at this point in time, not be as clear as we may have desired. But we perform and we measure, and then we treat patients accordingly. Looking to the primary endpoint, which was mortality and heart failure hospitalization, and addressing the difference between right ventricular pacing and the CRT group, were both endpoints, death and heart failure hospitalization, going into the same direction in parallel, or was the difference driven more by death or more by hospitalization?
I can't answer to that because we have, but I can answer precisely to this question. What I can tell you is that we have 688 events, and the majority of the events was death. 450 death and 250 heart failure. So it's mainly driven by death, but not exclusively.
Yeah, can I just add that this also has a wide geography representation, which is a bit unusual in Europe, and it even goes into North Africa. So in that way it's interesting because the patients are representative from European everyday life, and that also strengthens, I believe, the study, that it's not just special centers that have been part of it.
I don't know if we've time to that, but I must say that there is difference between the BIOPACE and the BLOCK-HF trial, not only due to the ejection fraction, because we have this data on the subgroup of patients below 50%, but I must say that in BLOCK-HF there is 35%, around 35% of the patients that had a left ventricular branch block. We have only 15%. So in fact, in the BLOCK-HF trial, I think that they mostly recruited patients that are a candidate for CRT.
And that was different in BIOPACE.
In BIOPACE, we really include patients that had AV block.
Putting things into perspective, take-home message at this point in time from BIOPACE, Cecilia.
I think we need to digest these results carefully and put one more piece into the jigsaw puzzle, and that is, if you do get an ordinary DDD pacemaker as a patient with high degree AV block and develop heart failure, you respond very well to upgrading to CRT, and that is precisely what the guidelines of the ERA EHJ recommend to date. So this may still be the best approach in my mind until we know better.
Jean-Jacques, your perspective?
My perspective is that this big trial, because it's clearly the biggest trial in the field up to now, is that it always will put a question: should I put an RV, but perhaps a BIV pacing?
Celia, Jean-Jacques, thank you so much for this interview here at EHJ today.